Thank you. We're just about to start again. However, there's something I'd like to say. It's been brought to my attention, I should say, by Mr. Gale's junior counsel, who must have been talking to people during the coffee break, that some of the solicitors that are present here are busy and assiduously taking notes. Can I say that? Can I save them some work, to be perfectly honest? And I apologise, perhaps I should have thought about this yesterday, but this has all been recorded. There's, the availability of a transcript will be there, and you'll be able to get a transcript of this. I cannot say, I'll try and say perhaps at the beginning of the afternoon session when you can expect it, but my understanding is it should be available in very short order, probably next week sometime. So if that assists you and eases your hand muscles, I hope I'm doing some good. Right. Mr. Gale, when you're ready.
Thank you, my Lord. Just another piece of housekeeping. Excuse me. Another piece of housekeeping. Dr. Croft referred to the the Cochrane review of remdesivir, which he handed a copy, I think, to you. There is now a copy available for your Lordship.
Thank you.
And we have copies. If anybody wants a copy, it'll be available perhaps at lunchtime to be picked up. Fortunately, it's not quite of the length of the other Cochrane reviews that we have. It's only 2 pages, so it's manageable. Right. Dr. Croft, can we go back to your statement at 228, please? Because you begin here with a consideration of probably what is a general but discrete area, and is in context of how is COVID prevented, and there are various aspects of that. We will look at this in some more detail in section 3 of your report, which we will be going to next, and in particular the physical measures taken against COVID. But perhaps you can just take us through, first of all, the general public health measures that you identify.
Yes. Shall I read on?
Yes, please read on.
So, general public health measures to prevent COVID-19. COVID-19 may be prevented through standard infection control measures, along with the public health management of infected cases. The most basic public health measure against COVID-19, which was implemented in all countries during the pandemic, was promoting frequent hand washing. Large-scale frequent surface decontamination efforts were deployed in public spaces, but the effect of these cleanings on reducing transmission was and remains uncertain.
Yes, I think that's something we'll be
Yes.
touching on in due course.
We will, yes.
You move on now to PPE.
So the second category of prevention is PPE. All countries advise the use of personal protective equipment, PPE, by frontline healthcare staff during the COVID-19 pandemic. And challenges included the rapid depletion of PPE, the lag between the spread of infection and the acquisition of evidence needed to inform precautions to control its spread, and frequent changes in PPE guidance in response to its availability.
And I think, just pausing there, I think one of the other challenges may also have been the varying quality of some PPE.
Yes. Yes, indeed. And most countries recommended, and in some cases enforced, the use of face coverings by all adults, and not simply healthcare staff, in places where close contact was likely.
Now we move from, as it were, PPE and general health measures to lockdowns. Now, I think you commented yesterday under reference to the approach taken by the government of China in relation to lockdowns. And I think the terminology came from that time. Would you just read on, please, at 2:30?
Yes. of course, there's a definition of lockdown in the...
There is, yes.
We will take that as read. So a major strategy for attempting to limit the spread of SARS-CoV-2 was the introduction by some governments, starting with China, of extreme physical distancing measures, and these have been termed lockdowns. The components and restrictiveness of lockdowns varied, and not all countries employed lockdowns. Where lockdowns against COVID-19 were introduced, they typically included, and there's a list here, the closure of schools, workplaces, non-essential shops, sporting and entertainment venues, a move to remote, i.e. computer-based working where possible, banning mass gatherings, curfews, stay-at-home orders, and other local, national and international travel restrictions. And then in some countries where extreme physical distancing measures were employed early in the COVID-19 pandemic, e.g. New Zealand, they resulted in complete, although temporary, eradication of virus in the community.
You say there that in relation to New Zealand,
Yes.
it was a complete, although temporary, eradication of the virus. What happened after that temporary eradication? Do you know?
I'm assuming what means there is that the lockdown temporarily there were no COVID cases because they had a policy of zero COVID, but then new cases emerged, and that's something that does need investigation. I believe there may be some evidence taken from New Zealand later on. The same was seen in China, of course, where even this year, even earlier this year, they were still having intermittent lockdowns focused on particular cities, and they only abandoned it because of severe public unrest.
Yes. Right. The next area of prevention is social distancing, and again, would you read that, please?
Yes. Social distancing. In countries where extreme physical distancing measures, i.e. lockdowns, were not considered necessary or else were temporarily relaxed, social distancing strategies were employed instead. These involved keeping people physically separate, and a target of greater than or equal to 2 meters was used in the UK. Vulnerable adults, including older and immunocompromised people, were advised to curtail all social interactions. This strategy was named shielding in the UK.
And finally, in this section, test, trace and isolate measures.
So test, trace and isolate measures, other measures used to limit or attempt to limit the spread of SARS-CoV-2 were high levels of case identification with widespread testing in order to identify cases and ensure public health follow-up of potential cases, and enforcing quarantine measures for cases, contacts and travellers from high-incidence countries. A combination of such strategies has been termed test, trace and isolate, TTI. And then more novel approaches to limit or attempt to limit the spread of SARS-CoV-2 included the use of mobile phone apps, and also, depending on jurisdiction and legal constraints, use of CCTV footage and tracking of a contact's digital signature. And in the UK, including Scotland, other countries also, the processes of death certification was streamlined in early 2020 to deal with anticipated surges in deaths.
What's the significance of that? The significance is that where, under certain conditions, a pathologist is required to perform a post-mortem, but those conditions were relaxed significantly, and for a time I believe post-mortems weren't even being done on COVID-19 cases. So to some extent the certainty that could be attributed to whether or not the person died of COVID-19 or with COVID-19 has to be considered a compounding factor in assessing the mortality. It wasn't done to, if you like, obfuscate the situation. It was a practical measure to deal with the anticipated very large number of deaths. Right. Now, at 233, page 42, we go on to the sixth aspect of prevention, and this is, in terms of what you say, the most detailed, and that's vaccination. Now, again, vaccination is something we're going to come to
Yes.
in section 4
Yes.
of your report. So I'm going to take this, with respect, relatively short.
Yes.
And I think we can see at the very beginning, COVID vaccine was developed at record speed, and you identify 4 factors for that: prior research, the state of vaccine technology, abundant funding, and a large group of willing volunteers. I think probably everybody who, again, remembers the circumstances of the pandemic and the development of the vaccine, and without the level of information that you would have had, probably thought, as expressing personal view here, as indeed did I, that vaccine, I expected, would have taken a great deal longer than it did. You've identified these factors. Was there any worry about the fact that it was developed so quickly?
Well, yes, people have expressed concern, and people were expressing concern at the time, and ideally a vaccine should be developed over a period of time to allow close understanding of how the vaccine may benefit the population, and equally how harms may arise that might not be foreseen at first. So the speed of development was of concern. Then some vaccines are developed quickly, and vaccines for seasonal influenza are often developed quite quickly because they'll be based on the previous season's circulating virus. And typically they're developed in 7 or 8 months. The influenza season ends, and the companies that make vaccines start to develop the one that they anticipate will be effective in the next season. So there is some there are some precedents for fast vaccine development, but in general it's not ideal to develop a drug or a vaccine at high speed because it means that potentially key stages in the analysis of either the efficacy or the harms might be missed or skipped over.
One of the things you mentioned, and I think you've already mentioned, but at page 43 in the first paragraph, you mentioned that vaccine development, the phases were often run concurrently, so that had the effect of speeding up the process.
Yes.
And I think also it's fairly obvious that this was a situation at which, if one can say it, money was little object.
Indeed, yes.
Yeah. Now, at the you give a date of the 27th of July 2020 in relation to the Pfizer-BioNTech vaccine, which and of the Moderna vaccine. And I think then you say that globally vaccines against COVID-19 fall into one of 3 categories.
Yes.
It's perhaps useful if you just explain this. I think we probably touched on it a little yesterday in relation to viral vector vaccines.
Yes.
Perhaps you could just explain the difference, what each category of vaccine is and what are the differences.
Yes, so the vaccine is works by presenting antigens from the pathogen to the body's immune system, and the pathogen is surrounded by a number of molecules that the body's immune system will recognize as foreign, and the trick is to work out which of these molecules are particularly antigenic, which are the ones that especially trigger an immune response, and then put those into your vaccine, and in that way trigger an immune response before the body is exposed to the pathogen. And so component vaccines in very crude terms, are conventional vaccines, and you could regard them as being mashed up virus, just mash it all up, injected into the person. It's not quite as simple as that, because in general there's an attempt to try and extract some components from the whole architecture of the virus and put them into the body, if you like, preferentially. But that's a very rough way of looking at conventional vaccines.
Mm-hmm. Can you give an example of a conventional vaccine?
Yes, for example, a conventional vaccine would be, for instance, the smallpox vaccine, which was efficient in eradicating smallpox in 1978. And that was effective because smallpox is a DNA virus, and DNA viruses are more stable, and so therefore if you achieve immunity against smallpox, you will never get smallpox. And so you can vaccinate against smallpox, and it'll be very effective for your whole life. So that was a conventional vaccine.
And of course, coronaviruses are RNA viruses.
Well, this is the next sort of vaccine. It's possible to have a conventional vaccine against coronaviruses, because you just mash up the virus and inject it into patients. And in very crude terms, that was what was done with the conventional technology that produced conventional vaccines.
Right.
But there was a new approach, which was a genetic approach to COVID-19. It had been tried out in over about the previous decade, really since SARS, and the idea was to the idea of the genetic approach really was to instruct the body of the host, the human host, to produce antibodies that would stop the virus from entering the cells. So we mentioned the spike protein earlier on, that is the L key that attaches to the receptor on the cells, opens that fuses with the receptor and opens the cell membrane so that the virus can get into the cell. So the spike protein was based on earlier research with SARS. The original SARS virus was judged correctly to be if you like, the key to achieve entry into the cells, and so therefore was the target for these the genetic approach to designing vaccines.
Right. Now, you explain, you refer also to viral vector vaccines again.
Yes.
And that is, you say, using novel technology.
Yes.
Can you explain, please?
Yes, so there are two ways of instructing the cell to produce antibodies against. Actually, I jumped ahead a bit. You're instructing the body to produce spike protein, and then the immune system of the body then recognizes that spike protein and produces antibodies. I should have made that clear. That's the nature. That's the way vaccines based on genetic approaches work. They instruct the body to produce spike protein. So you produce spike protein, and then your immune system recognizes the spike protein and responds to that by producing antibodies. So viral vector vaccines, they work by modifying harmless viruses that are not going to produce disease when they're injected into an individual. And the viruses are modified so they're carrying the DNA that the DNA being a genetic code that that instructs the body to produce manufacture spike protein. And the RNA viruses work slightly differently. They're carrying messenger RNA, which goes into the cells, into the nucleus of the cells, and the nucleus, and then I better close check this one. Essentially, the end result is that the cells likewise produce spike protein, but through two slightly different approaches.
Right.
So,
you've set out, or I've taken a table,
yes,
which we can find at page 44
yes,
of your report. And I think at the bottom of page 43, 43, you say the distinction between conventional and novel technology viruses are shown in the table over leaf. And the first three categories in the table are shown, and these are live attenuated vaccines,
Yes.
Inactivated, killed off whole cell vaccines and component vaccines. So the component vaccine was the one that you were referring to in your text. But thereafter, we're looking at novel technology. Does that have any meaning other than the fact that it is new? Say novel technology, or does it imply something beyond it being a newly developed technique?
It's a way of categorizing vaccines that is helpful. The first two categories are really the traditional ways. The component vaccines are kind of relatively modern ways by which they try and identify particular components of the pathogen that are likely to be especially immunogenic, and the components are concentrated in the vaccine. So they're an advance on the earlier two categories. And then the two bottom categories are the genetic approaches to producing vaccines.
So there's two categories of the viral vector vaccines and the nucleic acid vaccines.
Yeah, exactly, yes.
And I think we can see that COVID-19 falls within both the viral vector vaccines and the nucleic acid vaccine, but also within the component vaccines, which I think you've explained as the you put it as the mashed up.
Yes. That's right. So just to reiterate, the viral vector vaccines carry DNA that codes the spike protein. They go into the nucleus, and the nucleus produces messenger RNA, which goes to the ribosomes, which produces spike protein. The bottom category have RNA, which sort of bypasses the first process. The RNA goes straight to the ribosomes and produces spike protein. We can perhaps elaborate on that a little bit later.
Yes.
It comes a bit later in my report.
Yes. At page 45 at the top, you say that in the States, 2 mRNA vaccines were approved, received emergency use authorization in December 2020 by the FDA. And these were the Moderna vaccine for use in individuals 18 and over, and the Pfizer-BioNTech vaccine, again, for use in in a similar, not quite similar, 16 or over age group. So you pass on then to look at the initial COVID vaccines procured in the UK. And I think you've again, taking this short, you've listed 4 vaccines there: the AstraZeneca, the Janssen, the Moderna, and the Pfizer-BioNTech. And I think at the bottom of the page 45, you notice that the UK government did announce in April 2021, that 20 million doses of the Janssen vaccine had been ordered from the manufacturer. But you go on to say that this vaccine has never been used in the UK.
Yes, that's my understanding. And later on, I think we may have a time to consider the MHRA report. And they have nothing to say about Janssen vaccine because it hasn't actually been used on the public.
Am I right in thinking that it was used in Ireland?
I believe it was used in Ireland. Yes, it was.
But we don't at present, and you are not able to assist us in knowing what happened post the ordering of 20 million doses.
Where the order went to, we don't know. I don't know.
The following page at 46, you deal with later COVID-19 vaccines procured in the UK. And again, you've provided these. And I think this takes us into booster use.
Yes.
And I think you've set that out in the second paragraph. And then at 236 of your report, you talk about the current vaccination program against COVID-19 in the UK. And you summarize that. And I think you say to begin with that there were three, and I think they're fairly obvious aims, was to provide protection for individuals who are considered at highest risk of severe illness or death from COVID, to reduce hospitalizations, and to protect frontline and health and social care staff from exposure.
Yes.
And I think that you then go on to indicate that all UK adults and children aged 5.5 or over are currently eligible for a primary vaccination course. Just explain what a primary vaccination course is. Probably is obvious.
Oh yes, I think I might have the wrong citation. I do beg your pardon. That citation should be to the British National Formulary.
Oh, right.
Yes. It's
Well, with that correction, can you just tell us what a primary vaccination?
Primary vaccination means that the initial exposure of the recipient to the vaccine. So some vaccines are just a one-off exposure. Just one vaccine will give you protection for life. Some require 2 or 3 sequential vaccines separated by a defined time interval in order to achieve immunity to the pathogen being immunized against.
Yes.
So, for example, hepatitis B vaccination, which I've had, which all doctors have to have, it's normally it's normally 3 courses of hepatitis B vaccine that you have over a period of 6 months, and that generally gives lifelong immunity to hepatitis B, which is a DNA virus, so you would expect
Yes. And I think it's page 47, the first full paragraph, you note that the manufacturer's initial advice during 2021 was that COVID-19 vaccines should be administered as a 2-dose schedule with 3 to 4 weeks between each dose.
Yes, some manufacturers had a slightly different interval, but the idea was there should be a first dose, then an interval of some weeks, and then a second dose. But,
And again,
that was the idea.
I think with other things that we will look at,
Yes.
that is obviously dependent on the willingness and the ability of the person to attend for the second dose.
Yes. Yes.
So there could be some failures in the in that program.
Yes.
Yes. At one point you raise it's a single paragraph in the middle of page 47, is that where possible the same COVID-19 vaccine should be used for the entire primary course.
Yes. Yes.
Has that always been possible, do you know?
It's a standard principle of immunization technique, strategy, that when you have a vaccine that requires 2 or 3 doses, you will try and use the same vaccine for each of those doses, because vaccines tend to work slightly differently, and you may not achieve proper immunity by chopping and changing as to what vaccine you use.
Now, in the next 2 sections, Doctor, you look at the way in which novel COVID-19 vaccines work.
Yes.
You look first at vector vaccines and then mRNA vaccines, going over onto page 48. And again, I will, with respect, take that as read from you without going into the detail of it. But I would like to look, please, at 239 at page 49, which are booster doses.
Yes.
And I think you note at the beginning that at September 2021, Israel became the first country to demonstrate waning protection from Pfizer vaccine, showing a decline in protection even against severe disease at around 6 months. And this was perhaps at least the booster for boosters, I suppose, and put it that way.
Yes.
This was something that set us on the trail of booster
Yes,
doses.
indeed. I think it had been hoped that boosters wouldn't be necessary. Clearly the hope was that two doses would give extensive protection for a long period of time, but it became apparent this wasn't the case, and the idea of boosters then came in.
And I think at the I think you say, perhaps useful to note, in the penultimate paragraph on page 49, that protection against hospitalization after an mRNA booster reaches over 90% in 2 weeks after vaccination, and then declines towards a stable plateau of around 60% by 6 months. Again, is that something that was expected?
With hindsight, and given the, as you described it, Mr. Gale, the fact that we were dealing with a moving target, it should have been expected, but I don't think that was conveyed to the general public as a likely outcome.
Yes.
Certainly in England, the expectation was we went into lockdown, but the vaccines were coming and they would release us from lockdown and everything would return to normal pretty much straight away.
Yes. Yeah. So you set out at the bottom of page 49 the current UK practice in relation to the offering of a first booster. Perhaps you just take us through that, please.
Shall I read it out?
Yes, please.
So current UK practice, and this is drawn from the latest text in the Green Book, which I've got here, which April 2023, I believe, is to offer a first booster at least 3 months after completion of primary immunisation to the following groups. And there are 3 groups. Firstly, all individuals aged 16 and over. Secondly, children aged 12 to 15 years in clinical at-risk groups or who are household contacts of immunosuppressed individuals. And thirdly, children aged 5 to 11 years with severe immunosuppression.
Perhaps you just carry on
yes.
to the bottom of that section, Doctor.
And then, as well as boosters of the primary course, there's also seasonal boosters that are programmed for spring and autumn every year. And the current UK practice is a seasonal booster, in addition to any booster you might already have had for your primary course, should be offered provided there's been an interval of at least 3 months from the previous dose to the following groups. And there are 6 groups here. Firstly, residents of and staff working in care homes for older adults. Secondly, frontline health and social care workers. Thirdly, all individuals aged 50 years and over. Fourthly, individuals aged 5 years and above in a clinical at-risk group. And fifthly, individuals aged 5 years and over who are household contacts of immunosuppressed individuals. And finally, individuals aged 16 years and over who are carers.
Yes. You go on now to discuss specific patient groups, and first group you look at pregnant females, and I think we've already touched on this matter. But you say that current UK advice is that pregnant females should be offered immunization against COVID-19 as pregnancy is a risk factor for severe COVID infection.
Yes.
So it's looking at it from that perspective,
Yes.
from the risk of infection.
Yes.
Yes. I think also we have individuals with severe immunosuppression, Again, we've touched on this. Perhaps it would be useful, just at this stage, if you gave an indication of what is understood in the public health field of severe immunosuppression.
Yes, so immunosuppressed people are those whose immune system doesn't work, either doesn't work at all or doesn't work efficiently to protect them against pathogens.
Yes.
And that could be because they have disease, either a chronic general disease such as diabetes or cardiovascular disease or kidney disease, or because they've got a disease specific to their immune systems like leukemia, so they have no white cells or very few white cells. Or alternatively, they may, or HIV disease, which is a disease of a subset of the white cells. Or alternatively, they may be taking immunosuppressant drugs, such as steroids or some of the current anti-cancer drugs, for example, methotrexate or monoclonal antibodies, and they work by deliberately suppressing the immune systems so as to dampen down the inflammatory reaction of the body.
Right. And I think what you say at the bottom of page 50 is effectively a summary of what is contained in the previous two paragraphs about, particularly about children.
Yes.
You also go on to say at page 51 at the top that current UK advice is that people with HIV infection, regardless of their CD4 count, should likewise be offered a third dose of COVID as part of the primary course, along with subsequent booster doses.
Yes.
Right. You now look briefly at an area that you entitle "How Safe Are COVID-19 Vaccines?" And you begin with thromboembolic clotting events. And perhaps you just read through that, please.
Yes. Thromboembolic clotting events. In early 2021, there were multiple reports of vaccine-induced immune thrombocytopenia, that means low platelets, and thrombosis, that means clotting, VITT, with the adenovirus vector vaccines Vaxzevria, which is the AstraZeneca vaccine, the Oxford vaccine, and Nuvazoxovid, which is a Janssen vaccine.
Yeah.
And VITT is a severe but rare blood clotting condition, and it develops within 5 to 30 days of receiving vaccination.
When you say that there were multiple reports, do we have a figure for those reports?
We have one later on. Yes,
yes.
we do, yes. Yeah. The citation I was using here, which was the British National Form, it doesn't particularly mention the figure, but there is a figure, yes.
Yes, okay. We'll come to that in due course.
Yeah.
And as you say, that as from early 2023, AstraZeneca was not routinely supplied in the UK, and Janssen, as we've already heard, was initially procured but has never been supplied.
Yes.
The second area of safety you look at is myocarditis. And again, if you would just read through that, please.
Yes, myocarditis. So the mRNA that is delivered to cells, messenger RNA, that's delivered to cells following challenge with COVID-19 nucleic acid vaccines, i.e. mRNA vaccines, is said to be normally degraded within a few days. There have been reports of vaccine-associated myocarditis, that means inflammation of the heart muscle, with all COVID-19 mRNA vaccines. Again, the quote there's from the British National Formulary. Although the mRNA monovalent vaccine, Spikevax, the Moderna vaccine, is licensed in the UK for use in children aged greater than or equal to 6 years, current guidance is that a preferred COVID-19 vaccine for use in children is the mRNA monovalent Pfizer vaccine, due to a lower reported rate of myocarditis with the Pfizer vaccine.
Right. You then go on to what are described as other adverse effects.
Yes.
And we will come in due course to look at the yellow card system and the report on that.
Yep.
And what we have here is, I think, a reference to it, which
Yeah.
is a 2-year analysis of yellow card reports, which report spontaneously reported vaccine adverse events. It was published in 2022 by the MHRA, documented to 2,362 spontaneous reports suggesting a fatal outcome following COVID-19 vaccination. While of concern, the association does not prove causality. So you are noting there that through the use of the yellow card report, there have been documented over 2,000 spontaneous reports of a fatal outcome. But of course that, as you say, is of concern. It does not prove causality. Is that
It doesn't, no.
Yes.
But it's still, it would be a high number that one would not expect to see with certainly most vaccines.
Yes. And the other adverse events commonly reported include, and you've listed them there, Bell's palsy, Guillain-Barré syndrome, which is ascending paralysis, transfer myelitis, spinal cord inflammation, and menstrual disorders and vaginal bleeding.
Yes.
Could you go on then, and I think I'll ask you just to read through, it's the final section in this part of your report, the future course of COVID-19.
Future course of COVID-19. So on the 5th of May, the World Health Organization declared that COVID was no longer a public health emergency of international concern. Epidemiological surveillance suggests that SARS-CoV-2, which is the cause of COVID-19, is now becoming endemic. That means it's circulating at about the same instance over a long period of time. And endemicity is a feature of the 4 coronaviruses that have been known for many years to cause mild to moderate respiratory tract illness, including the common cold. Potentially, SARS-CoV-2 can still cause severe illness in those not previously exposed to the virus, either through natural infection or through vaccination. And it's possible to model the possible future behavior of SARS-CoV-2 infection. No model, however, will be better than the assumptions on which it was built, and disease models are typically phrased in mathematical terms, which can make them difficult to understand for the non-mathematician and also lend them an air of exactitude that they seldom merit. And that's a quote from great Swedish epidemiologist Johan Giesecke, who's written a really very good book about infectious disease epidemiology.
I think that's the final footnote at
Yes, it is, yes.
footnote
Indeed, yes.
264.
Yeah.
Right. My Lord, I wonder if I could take 5 minutes simply to rearrange papers and
Of course, absolutely.
before we go into the next section. It will only be a few minutes.
Surely 5 minutes then, ladies and gentlemen. You're ready, Mr. Gill.
Thank you, my lord. Dr. Croft, going on
Yes.
to part 3 of
Yes.
your report.
Yes.
You deal here with physical measures taken against COVID-19. To a certain extent, this has already been prefaced
Yes.
in what we've been looking at.
Yes.
And you begin with a section in block here, and it's headed Specific Knowledge Pre-Pandemic. And this, I think, derives from the Jefferson 2011 paper, Cochrane Review.
Yes, that summarised the state of knowledge, yes.
And I wonder if you just, first of all, take us through the key messages,
Yes.
and then we'll look to a certain extent at the supporting statistics. But if you take us to the key messages, they're set out in the blog section at page 54 of your report.
That's right, yes, yes. And thank you, my lord. These key messages I cut and pasted from the review itself, page, they're on, from the plain language summary of the review, which is on page 355.
Yes.
That's right, yeah. Yeah. I think it's right at the very bottom paragraph, page 355.
Yes.
6 lines up starts. A big one, 6 lines up. Respiratory virus spread can be reduced by hygienic measures such as hand washing. Yeah, that's where all of that comes from.
Yes.
Yes. So these aren't my words. These are word-for-word transcriptions of the plain language summary, key messages for, if you like, for lay people, essentially.
Well, perhaps before we do that,
Yes.
we can have a look at the Cochrane
Yes.
Review. So if this is document number 8 within the bundle, and it's at page 354. And I think we can see there that the lead author is Tom Jefferson, who was at that time at the Centre for Evidence-Based Medicine at Oxford. Do you know Tom Jefferson?
Yes, I do know him. Yes, I haven't seen him for 20 years or so, but I know his name. He trained at Glasgow in medicine.
And I think just looking at some of the detail of this, the publication status and date,
Yes.
it says, that albeit it's 2011, it says it,
Yes.
edited, but no change to conclusions, published in issue 4, 2020. So there has been some, presumably, iterative updating of the document, but as it says, no change in conclusions.
Yes.
And then if we go on to the abstract,
Mm-hmm.
we can see that the background is, as it says, viral epidemics or pandemics of acute respiratory infections like influenza or severe acute respiratory syndrome pose a global threat. Antiviral drugs and vaccinations may be insufficient to prevent their spread. That's the context in which the authors of the Cochrane Review were proceeding.
Yes.
And then what is then set out are the objectives, and these are as it seems a single objective, to review the effectiveness of physical interventions to interrupt or reduce the spread of respiratory viruses. We then have a passage on search methods, and I think we can, with respect, pass over that. And then some information about selection criteria, which may be quite interesting just to read. It says, in this update, 2 review authors independently applied the inclusion criteria for all identified and retrieved articles and extracted data We scanned 3,775 titles, excluded 3,560 of them, and retrieved full papers of 215 studies to include 66 papers and of 67 studies. We included physical interventions, which included screening at entry ports, isolation, quarantine, social distancing, barriers, personal protection, hand hygiene to prevent respiratory virus transmission. We included randomized controlled trials, cohorts, case controls, before, after, and time series studies. And then we go on to see on the following page at 355 the main results. Now, these are obviously preparatory to what is contained within the plain language study. I think it might be useful, Doctor, if you would just read out what were the main results
Yes.
so far as the authors were concerned at that time.
Yes, so main results, this is on page 355, my lord. We included 67 studies, including randomized controlled trials and also observational studies with a mixed risk of bias. And a total number of participants is not included, as the total would be made up of a heterogeneous set of observations, in brackets participant people, observations on participants, and countries, in more brackets, object of some studies. The risk of bias for 5 RCTs, 5 randomized controlled trials, and most cluster randomized controlled trials was high. Observational studies were of mixed quality. Only case control data was sufficiently homogeneous to allow meta-analysis. The highest quality cluster randomized controlled trials suggest respiratory virus spread can be prevented by hygienic measures, such as hand washing, especially around younger children. Benefit from reduced transmission from children to household members is broadly supported also in other study designs where the potential for confounding is greater. 9 case control studies suggested implementing transmission barriers, isolation and hygienic measures are effective at containing respiratory virus epidemics. Surgical masks or N95 respirators were the most consistent and comprehensive supportive measures. N95 respirators were non-inferior, meaning they were the same, to simple surgical masks, but were more expensive, uncomfortable and irritating to skin. Adding virucidals or antiseptics to normal hand washing to decrease respiratory disease transmission remains uncertain. Global measures such as screening at entry ports led to a non-significant, meaning statistically non-significant, marginal delay in spread. There was limited evidence that social distancing was effective, especially if related to the risk of exposure.
Right. Just as a matter of detail, and I think we'll come to look at this in some detail later on. N95 respirators, what are they?
I would hope they would define them, but they're clearly some kind of advanced respirator which isn't just a cloth mask. They must incorporate some kind of screen.
So it's not sort of an advanced form of surgical mask. It is something, and clearly they have the potential, as is observed there, to be uncomfortable and irritating.
Yes, yeah.
What does respirator mean?
A respirator as a gas mask, basically. So that it's not just relying on cloth; it's relying on some kind of screen or mesh. And certainly military gas masks, which I'm familiar with, there's a charcoal filter as well. So the air goes through a filter, but it's one step up from surgical masks.
Yeah.
But in any event, they're no more effective than surgical masks.
Right. Doctor, we go on then to the author's conclusions, which are just in 2 lines. Would you read those out, please?
Author's conclusions. Simple and low-cost interventions would be useful for reducing transmission of epidemic respiratory viruses. Routine long-term implementation of some measures assessed might be difficult without the threat of an epidemic.
And then we have the plain language summary, which forms the basis for what is on page 54 of your report.
Yes.
So from whichever source you want, can you read out what the plain language summary and the key messages are?
Yes. Shall I just go to the second paragraph, Mr. Gale?
Yes.
Yeah. The first paragraph is background. So the second paragraph, we included 6 to 7 studies. Mixed risk of bias for the observational studies, and that's a reference to the hierarchy of evidence. They're saying they're observational studies, but they're likely to be biased. Some of them very biased, some of them slightly biased. And then they go on to say, third line down, this is where I take up my quotations, direct quotation, respiratory virus spread can be reduced by hygienic measures, such as hand washing, especially around younger children. Frequent hand washing can also reduce transmission from children to other household members. My third bullet point was the next one. Implementing barriers to transmission, such as isolation and hygienic measures, for example, wearing masks, gloves and gowns, can be effective in containing respiratory virus epidemics. It says or in hospital wards. I think there's some words missing. I think it probably there's probably some words there that was in clinics or in hospital wards, because they're quite emphatic that the evidence for these barriers to transmission is strong for healthcare environments, but it isn't strong in the community generally.
Yes. So we shouldn't just restrict it to hospital wards.
Well, we should restrict hospital wards and clinics. I think
Yes,
that's what they're saying,
yes.
But they're saying there's not much evidence that these type of barriers are useful in the community, although, of course, they're relatively cheap. We found no evidence that the more expensive, irritating and uncomfortable N95 respirators were superior to simple surgical masks. It is unclear if adding virucidals, that's chemicals that kill viruses, or antiseptics to normal hand washing with soap is more effective. So they're saying probably hand washing with soap is probably as effective as the more complex agents. And there's insufficient evidence to support screening at entry ports and social distancing, which they define as spatial separation of at least 1 meter between those infected and those non-infected, as a method to reduce spread during epidemics. And the reason there's insufficient evidence is probably because high-quality randomized control trials haven't been done. And most of their data is, they admit, is taken from case-control studies and even with level 2B evidence and studies that are even less powerful evidence than case-control studies. This is in contrast with the later review, which they focus very much on randomized control trials.
Well, perhaps we can look at the later review after lunch, my lord. It might be an appropriate point to pause.
Very good. Again, we stop a little early, so we'll come back a little earlier, about 20 to 2, please. Very good. Right, good afternoon, everyone. Mr. Gale, when you're ready.
Thank you, my Lord. Dr. Croft, we're looking at the Cochrane Review, the Jefferson paper, and we had looked at the plain language summary, which you replicate at page 54 of your report. I wonder if we could just look a little more at that Jefferson paper. Could you go, please, to page 367 within the paper?
Yes.
And I think we can see there that there's a summary of the evidence, and again, it's perhaps a slightly arduous task, but I wonder if you'd just read through that, and so we have that into the notes, please.
Yes, so the evidence seems to be mainly based on cluster randomized trials, and we know what they are now. So the highest quality cluster randomized trials indicate most effect on preventing respiratory virus spread from hygienic measures in younger children, and perhaps this is because younger children are least capable of hygienic behavior themselves, and have longer lived infections and greater social contact, thereby acting as portals of infection into the household. Additional benefit from reduced transmission from them to other members of the household is broadly supported by the results of other study designs, where the potential for confounding is greater. Shall I carry on?
Carry on. Yes,
okay.
just carry on. Really, for the
The
extent of the evidence as
Sure.
summarised.
The pooled case control studies, and those are level 1B evidence, the pooled case control studies, which focused on the SARS coronavirus, suggest that implementing barriers to transmission, isolation and hygienic measures are effective with the use of relatively cheap interventions to contain respiratory virus epidemics. We found limited evidence of the superior effectiveness of devices such as the N95 respirator over simple surgical masks. This evidence is supported by a high-quality hospital-based trial which reports non-inferiority between face barriers, meaning face masks are the same as N95 respirators. Overall, masks were the best performing intervention across populations, settings and threats. More expensive and uncomfortable, especially if worn for long periods, than simple surgical masks, N95 respirators may be useful in very high-risk situations, but additional studies are required to define these situations. It is uncertain whether the incremental effect of adding virucidals or antiseptics to normal hand washing actually decreased the respiratory disease burden outside the confines of the rather atypical studies upon which we reported. The extra benefit may have been at least in part accrued by confounding additional routines. Studies preventing transmission of respiratory syncytial virus and similar viruses appeared to be closer to real life and suggest good effectiveness. However, methodological quality concerns of the controlled before and after studies mentioned previously suggest benefits may have been due to population differences, especially virus infection rates. These were poorly reported in most studies. Routine long-term implementation of some of the measures assessed in this review would be problematic, particularly maintaining strict hygiene and barrier routines for long periods of time. This would probably only be feasible in highly moated environments, such as hospitals, without a real threat of a looming epidemic. Most of the trial authors commented on the major logistic burden that barrier routines imposed at the community level. However, the threat of a looming epidemic may provide stimulus for their inception. A disappointing finding was the lack of proper evaluation of global and highly resource-intensive measures, such as screening at entry ports and social distancing. The handful of studies, mostly conducted during the SARS epidemic, do not allow us to reach any firm conclusions. And they end by saying it's remarkable, despite a long lead time to the declaration of the pandemic, an international prospective study to evaluate entry screening practices was not set up. The study by Cowling et al. Is a good contribution to our evidence base, but no substitute for a well-designed and conducted trial. Finally, few studies reported harms from the intervention studied. Harms affect compliance, which may decrease. Compliance may decrease even if the intervention is merely cumbersome, such as a mask, and the threat is unclear.
I think one of the interesting points to draw from that summary is what is contained in the penultimate paragraph in the left-hand column, that the authors note that routine long-term implementation of some of the measures assessed in this review would be problematic, particularly maintaining strict hygiene and barrier routines for long periods of time.
Yeah.
And I think they then go on to say that, in a way, attention might be focused were there to be a more urgent and pressing pandemic problem.
Yes.
And obviously that perhaps leads us conveniently on to where we are now.
Yeah.
Yes.
Yes, indeed.
Could you look, please, at would you look, please, at the author's conclusions at paragraph 367 on the right-hand column?
Yes.
And I think what the authors say there, they divide it into two sections. One is implications for practice.
Yes.
And then they go on to implications for research. For the present purposes, can we just look at the implications for practice?
Yes.
And I think what they highlight there, the following effective interventions should be implemented, preferably in a combined fashion, to reduce transmission of viral respiratory disease. And they're then listed: frequent hand washing with or without adjunct antiseptics, barrier measures such as gloves, gowns and masks with filtration apparatus, and suspicion diagnosis with isolation of likely causes. And they go on, special efforts should be focused on implementing the three above interventions in order to reduce transmission from young children, who are generally the most fecund sources of respiratory virus. And I think anybody who's had a child will know that getting a child to wash their hands is probably one of the larger difficulties of parenthood.
Yeah.
Yes. Right. For completion, Doctor, can we go to pages 464 to 466 within that? They're the last few pages in the first volume, my lord.
Yes.
And I think there we see the summary. Table 2 is the summary of main events.
Yes.
And I think we can see the events that were considered by the authors utilizing the randomized trials went from hand washing with an antiseptic, surface disinfection, gargling with iodine, nose wash, etc. I'm not going to go through them all, but that's a summary in tabular form of the results which they obtained.
Yeah.
Right.
Just commenting on that, obviously the left-hand column is the most reliable evidence, and then it's slightly less reliable. Left two columns are the randomized controlled trials,
Yes.
and then as you go to the right, you get less and less reliable evidence.
Excuse me, could we go to the other Cochrane review, which is document 9, and could we go to page 477? It's the first document in the second volume a lot.
Mhm.
Now, this is the Jefferson Cochrane Review of 2023.
Mhm.
And again, looking at, we can see at page 477 that its publication status and date is that it has been edited, no change to conclusions. It was published in 2023. It's not, no precise date is given. And again, looking at the abstract, we can see there that there's something that we've already read, but I think it goes further,
Yes.
where it says viral epidemics or pandemics of acute respiratory infections pose a global threat. Examples are influenza H1N1, caused by the H1N1 virus in 2009, severe acute respiratory syndrome, SARS, in 2003, and coronavirus disease, 2019, COVID-19. So just getting the context, we have material in here which has regard to the circumstances of the COVID pandemic.
Yes, we have now.
Yeah.
Yes, indeed.
Yes. And I think it goes on to say antiviral drugs and vaccines may be insufficient to prevent their spread. I think that's something that was also observed in the Cochrane 2011 abstract. It says this is an update of a Cochrane review last published in 2020, which I think we've seen.
Yes.
We include results from studies from the current COVID-19 pandemic.
Yes.
So we have information informed by the experience of that pandemic. And again, the objectives to assess the effectiveness of physical interventions to interrupt or reduce the spread of acute respiratory viruses. And I'm not going to read through them, but there's then selection criteria and data collection and analysis. And if one goes over to the next page,
Yes.
478, we see a passage from begins main results. And again, I don't intend to go through that in any detail at this stage. But I think the potential measures are then grouped. Medical surgical masks compared to no masks.
Yep.
N95 P2 respirators compared to medical surgical masks, and then hand hygiene compared to control. And then we find the author's conclusions there, and perhaps you would read through that, Dr. Croft, so we have it in the evidence.
Yes. Author's conclusions from the it's January 2023 Jefferson Updated Review. The high risk of bias in the trials, variation in outcome measurement, and relatively low adherence with the interventions during the studies hampers drawing firm conclusions. There were additional RCTs, randomized controlled trials, during the pandemic related to physical interventions, but a relative paucity given the importance of the question of masking and its relative effectiveness, and the concomitant measure of mask adherence, which would be highly relevant to the measurement of effectiveness, especially in the elderly and in young children. There is uncertainty about the effects of face masks. The low to moderate certainty of evidence means our confidence in the effect estimate is limited, and that the true effect may be different from the observed estimate. I think they mean the calculated estimate of the effect. The pooled results of RCTs did not show a clear reduction in respiratory viral infection with the use of medical oblique surgical masks. There were no clear differences between the use of medical surgical masks compared with N95 P2 respirators in healthcare workers when used in routine care to reduce respiratory viral infection. Hand hygiene is likely to modestly reduce the burden of respiratory illness, and although this effect was also present when influenza-like illness and laboratory-confirmed influenza were analysed separately, it was not found to be a significant difference for the latter two outcomes. Harms associated with physical interventions were under-investigated. And finally...
Just pausing on that, the reference to harms associated with physical interventions were under-investigated. It's not expanded upon there. What do you understand by that comment?
Well, harms is a broad term encompassing
Yes.
everything from inconvenience to death, and probably also including economic costs and societal costs. And
Yes.
that, I think, is what they're getting at, that some of the interventions carry a very modest or almost no risk of harm, and they would probably include, and almost none, they'd include probably hand washing, that they say you don't want to wash your hands too often, they said at one point. So they would carry almost no risk of harms, but other interventions, and here I think they'd include social distancing, and they said would have a greater risk of harm. They talk about the harms of closing international boundaries, and there I think they're just talking about the economic and the harms to people wanting to travel. That's a basic, a fundamental restriction on our civil liberties. So those are harms that are in a different category. The specialised respirators, it comes up again and again in the trials that people don't like wearing these close-fitting N95 and P2 respirators. So that the harms of that have to be taken into account, even though they might seem to be very effective. Nevertheless, are people really going to wear them when they're not in a highly disciplined environment like hospital? So it's a broad term, and this is a feature of randomised controlled trials. The authors want to stress the benefits of the new drug, the new vaccine, the new product that they've investigated, and they tend to downplay the potential harms, because that's kind of human nature.
And as I think you've indicated, the harms can range from matters of probably relatively insignificant harm, such
Yes.
as inconvenience,
Yes.
irritation, perhaps if we were
Yes.
looking at the N95 respirators,
Yes.
but across to more serious socio-economic harms.
Yes.
And
yes,
again, I think we discussed yesterday that you would see that as being part of your remit
yes.
as a public health
Yes.
consultant.
Yes. Yes. Indeed.
Yes. I think we go on to see again a plain language summary, and the key messages that are derived from the research by Jefferson and others are those that are summarized, are those that are reproduced at page 55 in the block section of your report.
Yes,
is that right?
They only have two key messages there, so I've just transcribed them directly into the report at page 55.
Yes. And I think, again, utilising the plain language summary, there's a list of physical measures set out there, which I think, again, are reflected elsewhere. And we also have a passage, what did we want to find out? And the authors say, we wanted to find out whether physical measures stop or slow the spread of respiratory viruses from well-controlled studies in which one intervention is compared to another, known as randomized controlled trials. Could I take you then to page 510? Which is a more expansive view or summary of the author's conclusions in the left-hand column. And I think we can possibly, well, again, can I burden you, Doctor, with reading through what is said there? I don't think it's necessary to intersperse the various studies, but if you could just read through the text under implications for practice.
Yes, implications for practice. The evidence summarised in this review on the use of masks is largely based on studies conducted during traditional peak respiratory virus infection seasons up until 2016. And 2 relevant randomised trials conducted during the COVID-19 pandemic have been published, but their addition had minimal impact on the overall pooled estimate of effect. The observed lack of effect of mask wearing in interrupting the spread of influenza-like illness or influenza/COVID-19 in our view has many potential reasons, including poor study design, insufficiently powered studies arising from low viral circulation in some studies, lower adherence with mask wearing, especially among children, quality of the masks used, self-contamination of the mask by hands, lack of protection from eye exposure from respiratory droplets, allowing a route of entry of respiratory viruses into the nose via the lacrimal duct, saturation of masks with saliva from extended use, promoting virus survival in proteinaceous material, and finally, possible risk compensation behaviour leading to an exaggerated sense of security. Our findings show that hand hygiene has a modest effect as a physical intervention to interrupt the spread of respiratory viruses, but several questions remain. First, the high heterogeneity between studies, meaning different study characteristics, but several between some, this may suggest there are differences in the effect of direct interventions. The poor reporting limited our ability to extract the information needed to assess any dose-response relationship, and there are few head-to-head trials comparing hand hygiene materials, such as alcohol-based sanitizer or soap and water. Second, the sustainability of hand hygiene is unclear where participants in some studies achieved 5 to 10 hand washings per day, but adherence may have diminished with time as motivation decreased or due to adverse effects from frequent hand washing. Third, there is little evidence about the effectiveness of combinations of hand hygiene with other interventions and how those are best introduced and sustained. And finally, some interventions were intensively implemented within small organizations and involved educational training as a component, and the ability to scale these up to broader interventions is unclear. Our findings with respect to hand hygiene should be considered generally relevant to all viral respiratory infections, given the diverse populations where transmission of viral respiratory infections occurs. The participants were adults, children and families, and multiple congregation settings, including schools, childcare centres, homes and offices. Most respiratory viruses, including the pandemic SARS-CoV-2 virus, are considered to be predominantly spread via respiratory particles of varying size or contact routes, or both. Data from studies of SARS-CoV-2, contamination of the environment, based on the presence of viral ribonucleic acid and infectious virus, suggests significant fomite contamination. Hand hygiene would be expected to be beneficial in reducing the spread of SARS-CoV-2, similar to other beta coronaviruses, such as SARS-CoV-1, Middle Eastern Respiratory Syndrome, and human coronaviruses, which are very susceptible to the concentrations of alcohol commonly found in most hand sanitizer preparations. Support for this effect is the finding that poor hand hygiene, despite the full use of personal protective equipment, was independently associated with an increased risk of SARS-CoV-2 transmission to healthcare workers in a retrospective cohort study in Wuhan, China, in both a high-risk and low-risk clinical unit for patients infected with COVID-19. The practice of hand hygiene appears to have a consistent effect in all settings and should be an essential component of other interventions.
I think I can stop you there, Doctor. The summary of the main results, and I simply give the reference to this, is to be found at pages 770 to 772.
Yes. In the tables.
In the tables,
Yes.
that's it.
Yes.
And it's an overall summary. Each area of study is also given us as a summary as well. So the detail is there, and then it is aggregated into a final table.
And interesting, these tables compared to the previous ones, they're focusing on randomized controlled trials. They don't
Yes.
include the others, not in the tables.
There's one matter that I'd like to ask you about, and it takes us back to page 509 in the Jefferson Review, which is quite close to where we were previously reading. And I think in the right-hand column towards the top of 509, there's a paragraph which begins that the two RCTs of medical surgical masks during SARS-CoV-2 pandemic found uncertain evidence of small or no effect.
Yes.
The study by Abeluk in 2022 found a statistically significant benefit of masks versus no mask for COVID-like illness. However, this study was rated at high risk of bias for 5 of the 6 domains due to issues including baseline imbalance, subjective outcome assessment, and incomplete follow-up across the groups. Despite this study contributing 45% of the weight towards the meta-analysis of influenza COVID-like illnesses for masks versus no masks, the updated conclusions from the analysis strengthened around little or no effect of mask use.
Yes.
And those two studies, I think you've helpfully reproduced at appendix, I think it's appendix 5. My Lord, if the Lord wishes, and anyone else wishes the references, the study by Abeluk is in the bundle at pages 952 to 964. And the study by Bundergaard is at pages 965 to 974. Perhaps we can shortcut that by looking to appendix 5, please.
Yes.
And perhaps you could just help us by taking us through what was the Bundergaard study was, I think, in Denmark.
It was carried out in Copenhagen, I believe.
Right.
Yes.
And the Abeluk study was carried out in Bangladesh.
Yes.
Yes. Perhaps you just take us through what you say, and first of all, in relation to the Bundergaard study.
Yes. Should I just read it through?
Yes, please.
The Bundergaard study. The study was a randomized controlled trial carried out in Denmark in April-May 2020, i.e. at the start of the COVID-19 pandemic. At that time, mask wearing was not amongst the recommended public health measures in Denmark. There were 6,024 participants in the study, and they were community-dwelling adults, previously uninfected with SARS-CoV-2, who did not wear masks in their daily work, and they were randomized into either wearing a surgical mask outside the home for more than 3 hours, or not wearing a mask. The latter was the control group. And then testing for SARS-CoV-2 was carried out at 1 month. It's a very simple study, and nice flow diagram that is in there. At 1 month, 42, that's to say 1.8% of the mask-wearing participants tested positive for COVID-19, whereas 53, meaning 2.1% of the non-mask wearers were positive. The odds ratio was 0.882, suggesting a benefit from mask wearing, But once this was statistically analysed, the result was not significant. The confidence interval ranged from 0.54 to 1.23. So because the odds ratio crossed the line of no effect, this had to be considered an inconclusive study, an inconclusive finding, but an interesting study.
Yes. And I think we can see that at page 109 of your report in the appendix,
Yes.
the analysis 1.1,
Yes.
the comparison randomized trials, medical surgical masks
Yeah.
versus no masks, and I think we can see the Abaluk study is added into the list of studies
Yes.
and is the first in that list. So we can see the material that they were working from at that stage.
That's right. The Bungard one that we were just talking about, it's in the second block there, isn't it?
I'm sorry.
The Bungard one is
Bundegard,
the second
yes.
block, the third small red square, and you can see how the upper limit of the confidence interval does cross the line of no effect.
Yes. Yep. Would you go on to the Abaluk study, please?
Yes. The Abaluk study, this was a large group of investigators. Most of the investigators came from the United States. There are a few Bangladeshi investigators as well. And they carried out a cluster randomized controlled trial in rural Bangladesh in November 2020 to April 2021. And here the unit of randomization wasn't individuals, it was villages. So they enrolled 600 villages in the study, and the villages were randomized into either wearing a mask or else wearing a mask or and being shown a video and a brochure on how to use masks, or else no intervention. I do nothing. That was the control group. And then SARS-CoV-2 infection was determined in two ways, partly by self-reported symptoms that were consistent with COVID-19, and partly by laboratory testing. And the study authors concluded that the intervention, i.e. the wearing a mask and also being shown a video and given a brochure, the intervention reduced symptomatic seroprevalence. This is a composite measure of symptoms and antibody tests. The all-age odds ratio was 0.91, meaning that there was it showed a reduction in COVID-19 with an odds ratio of 0.9, so a modest reduction. The confidence interval there just touches 1, so they're only just significant because an odds ratio of 1 means no effect. And then I've got here the assessment, what the Cochrane reviewers have to say about these two studies.
Yes.
So the Cochrane reviewers looked at these two studies, which were obviously of great interest because they were carried out in the pandemic, and they interpreted the studies in the context of pre-existing evidence rather than the standalone studies, which is the correct way of doing it. And they applied the standards of scientific rigour that are routinely used in Cochrane reviews. They used the Cochrane risk of bias tool, and using this, the Bungard study was found to be at low to moderate risk of bias, and the Abaluk study at high risk of bias. And I included in this section of my report part of that.
Yes.
So the Abaluk is at the top, and you can see my lord, the five red signs indicate high risk of bias, and then coming down towards the bottom, Bungard's pretty good. It's got 3 greens, 2 reds, and one uncertain. Carrying on, when the findings of the Bungard and Abaluk studies were combined through meta-analysis with the findings of other previous pre-existing medical surgical mask randomized controlled trials, they contributed modestly to the overall finding that mask wearing may be effective in preventing the acquisition of SARS-CoV-2 infection, but statistically, using statistical rigour, and because the confidence intervals for the various pooled effect measures, and they're shown below as black diamonds, because confidence intervals in all cases include 1, the results are not significant. And then I show the actual the forest plot which compares medical surgical masks versus no masks using only randomized controlled trials, so very high quality evidence, and the outcome here is viral illness, various sorts of viral illness, but including SARS-CoV-2 illness. Abaluk is the very top line. What does it show? It shows they had. They seem to they disaggregated the villages into a number of participants. So the ones they had 111,000 villages who were wearing the masks and 155,000 who weren't wearing the masks, and you could see there seems to be a modest effect. It's a large red square indicating a large number of participants, but even then the final, if you go down 8 rows, the black diamond is the pooled estimate of effect, and that plainly does cross the line of no effect. So pooling all the evidence from all the studies indicates, shows with a degree of reliability that there's really no effect statistically from wearing a mask versus no mask in the community. That's what we're talking about. We're talking about community studies. And for hospital studies and clinic studies, there's no dispute about it. They're good. But in the community, the benefit hasn't been shown.
Now, the reference to Abaluk and Bundergaard
Yes.
are significant, obviously, for inclusion within the 2023 Jefferson
Yes.
Cochrane Review,
Yes, that's right.
in that they are randomized trials taken during the COVID pandemic.
Correct.
You said on a number of occasions that the Cochrane Review process
Yes.
is a dynamic process.
Yes.
Would one expect there to be further such trials emerging in the either at present or
Yes.
have already emerged,
Yes.
and in the near future?
Yes. I'm pretty sure other studies are emerging. They may even refer to some. Sometimes Cochrane reviews say we're aware of other studies going on, but we haven't got the findings yet. But we'll report about them later on.
Yeah. So effectively, what one has,
Yes.
based on Abaluk and Bundergaard, and indeed
Yes.
the other,
Yes.
is a conclusion drawn by the Cochrane reviewers, which is static as at
Yes. Indeed.
2023,
Yes.
as at this year.
That's right. Yes,
Yes.
indeed. In fact, it's not as of this year, really, Mr. Gale. It's probably whenever the last day they did a search.
Yes,
I
yes,
think it's July 2022. But at that point, that's the point at which they stop
Yeah.
searching, and then they present their conclusions.
Yes, point taken. Thank you. Could we go back to your report, please, Doctor, and go back to 3.1. You've listed there, excuse me, this is at page 56,
Thank you.
and these are physical, you had it as physical measures taken in Scotland against COVID-19,
Yes.
and you then you've utilised the list that I think we've already looked at from
Yes,
Jefferson.
yes.
Perhaps you would read on from the bottom of page 56, the beginning when the COVID pandemic was declared.
When the COVID-19 pandemic was declared in March 2020, the response of most governments around the world was to safeguard their citizens by simultaneously advocating multiple protective physical measures, sometimes referred to as a layered approach to population protection, that had been deployed in earlier epidemics of acute respiratory illness. And this section of my report describes how in Scotland, as in most, I should say countries, it says counties, as in most countries, I beg pardon, a wide range of physical measures against COVID-19 was either recommended or else mandated from early 2020 onwards. Some of the measures were undoubtedly effective and others were harmful. In fact, they probably all were harmful to some degree, because even having to buy a mask, harms you. They cost £1, and yes, so but the harms were obviously more intense with some of the interventions.
Yes.
And so I give a little comment there.
Yes. So your comment, please?
My comment is, as the pandemic struck in early 2020, SARS-CoV-2 was treated as an acute respiratory virus. At that time, the best evidence for the effectiveness or otherwise the physical measures to prevent the spread of respiratory viruses was from a decade-old Cochrane review, Jefferson 2011. We called it Jefferson 1. This review was updated as the pandemic progressed and was reissued in a revised form towards the end of the pandemic, Jefferson 2023.
Now, what you then to go on to do, Doctor, in 3.1.1 is list the physical measures advised or mandated in the period from March to July 2020. And I think for sake of brevity, we will take those all as read. I think everybody of our generation will remember the event of the 23rd of March 2020, which is on page 55, when the then Prime Minister said, "You must stay at home. I give you this simple message," I think is how he prefaced it.
Yes.
So you make a comment about that at the towards the bottom of page 58, and perhaps you would just read that and perhaps expand on it, please.
Yes, this of course is my own comment as a professional public health physician. See the first scientific knowledge box above. During March to July 2020, there was limited scientific evidence, and in some cases no scientific evidence, e.g. as regards lockdowns, to support the physical measures that were mandated in Scotland against COVID-19. Such evidence as there was, e.g. in favour of mask wearing, mostly came from hospital settings rather than community settings, and arguably was not applicable to the general non-hospital population.
You say arguably. Can you explain the basis of that surmise?
Of course, yes. So, perhaps some policymakers might have extracted one randomised controlled trial that showed quite a strong effect in the hospital and thought, well, our people are disciplined or can be trained to be disciplined and can be trained or educated to use masks properly, so we will apply that to the general population. But the Cochrane Review authors were quite insistent that hospital environments were not the same as domestic environments, and hospital staff could be educated and to some extent monitored in the correct use and the consistent use of these inconvenient and uncomfortable measures.
I suppose also that it could be considered that there would be an ongoing education process in relation to the general population, particularly with the seriousness of the situation in which we were in.
Yes, that's true. They talk about the need to emphasise the importance of it and to the gravity of the threat that was being faced. Yes.
Oh, thank you. You then go on in 3.1.2 to list the physical measures advised or mandated in the period between August and December 2020. And again, I think we can just take that as read. And effectively, your comment at the bottom of page 59 is really the same.
It's the same, yes.
And then you talk about, in 3.1.3, the temporary easing of physical measures in the run-up to Christmas. And I think we all remember that there was a great deal of pressure on the policymakers and the politicians to allow us to have some form of Christmas in 2020. And I think you've indicated that those measures that were put in place by the Scottish Government. And then there's, at page 60 you comment again, which again is a comment in relatively similar terms to what you've already said. And perhaps you just read it out.
So again my professional comment, the easing of the centrally mandated COVID-19 restrictions over the 2020 Christmas period differed in different parts of the UK and the different nations. It's not clear to what extent, if at all, the easing of the restrictions was based on a better understanding of the pathogenicity and transmission characteristics of SARS-CoV-2.
And moving on, the next period you're looking at is the period up in early 2021, and you list those up to page 61. And obviously this is bearing in mind the terms of the inquiry's remit, taking it into the date on the 22nd of June when the then First Minister Nicola Sturgeon announced a new indicative date for the whole of Scotland to move to level 0 on the 19th of July 2021, provided all necessary vaccination and harm reduction measures were met. And again, could we just have your comment on that?
So, my comment. Physical measures intended to restrict the spread of SARS-CoV-2 remained in place in Scotland throughout 2021, and some were still in place in 2022. And there are more milestones, more bullet points, and they're at the appendix to this report. And all of those milestones I took from the official timeline that's on the inquiry website, which is extremely helpful.
Right. We move on now to part 4 of your report, dealing with vaccines, and I think we need to have this have in mind on this the material that you've already provided us with in section 2 of your report on vaccines.
Yes.
And give me a moment. Bear with me for a moment. Not apologies. Right, Dr. Croft, we're at page 62 of your report.
Yes.
Again, there is a block section in which you note the position post-pandemic, and it's headed, "What are the benefits and risks of vaccines for preventing COVID-19?" And there are certain key messages.
Yes.
And I'd be grateful if you'd just read through that, please.
Yes. These are taken from the Cochrane Review by Granier and colleagues, 2022. Key messages, there are 5 bullet points. Firstly, most vaccines reduce, or probably reduce, the number of people who get COVID-19 disease and severe COVID-19 disease. Secondly, there is insufficient evidence to determine whether there was a difference between the vaccine and placebo in terms of death, because the numbers of deaths were low in the trials. Thirdly, many vaccines likely increase number of people experiencing events such as fever or headache compared to placebo, and placebo is defined as a sham vaccine that contains no medicine but looks identical to the vaccine being tested. This is expected because these events are mainly due to the body's response to the vaccine. They're usually mild and short term. Fourth bullet point, many vaccines have little or no difference in the incidence of serious adverse events compared to placebo. Finally, most trials assessed vaccine efficacy over a short time and did not evaluate efficacy to the COVID variants of concern.
Now, I think we can find that material at the Granier Cochrane paper, which is paper number 7 and is at pages 50 and following. I think if we go to page 53 within the bundle. And can we just look at some of the accompanying text? Going to page 53, I think we can see the objective of excuse me, the objective of the research at the bottom. Well, let's start logically with the background. The background: different forms of vaccines have been developed to prevent the SARS-CoV-2 virus and subsequent COVID-19 disease. Several are in widespread use globally, and then the objective was to assess the efficacy and safety of COVID-19 vaccines as a full primary vaccination series or a booster dose against SARS-CoV-2. So that's the objective. We then have the research materials and I suppose methodology. And if one then goes on to the main results on page 54, I think we can see that the authors included and analysed 41 RCTs, assessing 12 different vaccines, including homologous and heterologous vaccine schedules and effective booster doses. 32 RCTs were multi-center, and 5 were multinational. The sample sizes were 60 to 44,000 participants. Participants were aged 18 or older in 36 RCTs, 12 years or older in 1 RCT, 12 to 17 in 2, and 3 to 17 in 2 others. 29 RCTs provided results for individuals over 60. 3 RCTs included immunocompromised patients. No trials included pregnant women. 16 RCTs had 2 2-month follow-up or less. 20 RCTs had 2 or 6 months, and 5 RCTs had greater than 6 to 12 months or less. 18 reports were based on pre-planned interim analyses. And there's then an indication of the risk of bias. Overall risk of bias was low in 8 RCTs, while 33 had concerns for at least one outcome. And we then see that in the main results, the authors divide this up into confirmed symptomatic COVID-19, severe to critical COVID-19, and serious adverse effects. And we can obviously read the data, if we wish, in respect of each of those trials. But then we have the author's conclusions at the top of page 55, and I wonder if you would just read that, please.
Yes. Author's conclusions. Compared to placebo, most vaccines reduce, or likely reduce, the proportion of participants with confirmed symptomatic COVID-19, and for some there is high certainty evidence that they reduce severe or critical disease. There is probably little or no difference between most vaccines and placebo for serious adverse events. Over 300 registered randomized controlled trials are evaluating the efficacy of COVID-19 vaccines, and this review is updated regularly on the COVID NMA platform.
And then I think significantly, the implications for practice. Would you read that?
Yes. Implications for practice. Due to the trial exclusions, these results cannot be generalized to pregnant women, individuals with a history of SARS-CoV-2 infection, or immunocompromised people. Most trials had a short follow-up and were conducted before the emergence of variants of concern.
No. To a certain extent, implications for practice there is excluding certain matters. What would you take from the author's conclusions and your review of what is contained in Grania Cochrane review? What would you take as the message for the implication for the practitioner?
What I take is the key messages that I extracted and
Yes.
put in my report, which follow in the plain language summary. So I could go straight to them or read them from here.
Yes.
And so the first message: most vaccines reduce or probably reduce the number of people who get COVID-19 disease and severe COVID-19 disease. Secondly, many vaccines likely increase the number of people experiencing events such as fever or headache compared to placebo, sham vaccine. And this is expected because these events are mainly due to the body's response to the vaccine, and they're usually mild and short term.
Yes.
Many vaccines have little or no difference in the instance of serious adverse events compared to placebo. However, I think there ought really to be a qualifying phrase to that little bullet point, as there is to the next one. So if I read the next one,
Yes.
it says, there's insufficient evidence to determine whether there was a difference between the vaccine and placebo in terms of death, because the numbers of deaths were low in the trials. So in the same way, I think really they should have qualified the previous phrase by saying that the numbers of severe adverse events were low, serious, and so therefore we can't make a firm conclusion about that. And then
Other than to note that the numbers were low.
the numbers were low, yes, numbers were low. So the numbers were low, so therefore the confidence intervals were wide. And yes, and then finally, most trials assessed vaccine efficacy over a short time and did not evaluate efficacy to the COVID variants of concern. That's really because many of the trials started before the variants of concern had even emerged, so therefore they're not to be blamed for that. It was just the way that history worked out.
While Mr. Gale is looking at his papers, can I take you back to page 54 under the heading Main Results?
Yes.
You told us when you were talking about protective measures that Cochrane Reviews did report on trials underway about which there was no result available at the time of authorship.
Yes.
I see in this particular Cochrane report there is an entry under main results. We identified 343 registered RCTs with results not
Yes.
yet available. Is that what it's talking about?
It is, but if you look at the what they actually did, the number of trials that they looked at, they initially identified 600, of which it narrowed it down to 41. So that's not to say that we're suddenly going to be confronted with 343 eligible trials in a year's time. Those numbers will be whittled down because many of them will actually be looking at something else, but they are potential randomized controlled trials that will provide results in the future. So there will be
Guessed where I was going.
yes, there will be an increase in the evidence.
There will be an increase.
There will be the evidence base will be enlarged
But
by
not
the
by 340.
not by no maybe by 4 or 5 or 10, and of course not all those randomised controlled trials are really relevant to the people of Scotland because they're looking at vaccines that were used elsewhere.
Yeah.
You see that they look at the whole range of vaccines.
Well,
And
notwithstanding those caveats,
yes,
is it likely, you may not know the answer to this,
Yes.
but is it likely because of the likely emergence of a number
Yes.
of randomised controlled trials, that there will be an update to this particular Cochrane review at
Yes.
some stage.
There will, I'm sure there'll be a hard copy update, and they're the important ones because they're the ones that are peer reviewed before they're launched. So there will be, I would guess, in maybe 2 years' time.
2 years' time.
Yes.
Sorry, Mr. Gill.
No, not at all, my lord. Thank you. Let's perhaps indulge in a little speculation, Dr. Croft. The key messages,
Yes.
the first of which is that most vaccines reduce or probably reduce the number of people who get COVID-19 disease and severe COVID-19 disease. Further research, and the Lord has just indicated
Yes.
the extent of that is noted as ongoing, and appreciate you saying that that will be filtered
Yes.
for those that actually input into a subsequent Cochrane review as edited.
Yes.
Would one anticipate that it may be possible that that terminology might be altered so that it could be increased in its strength, perhaps by removing the word probably?
Yes, that could be the case. Yes, if enough trials come along which are measuring that particular outcome and are judged to be suitable to include in meta-analysis. That's part of the catch-22. Not all of them are suitable. They might. What we might be looking at would be that's for mashed-up vaccines, for example, and not wishing to denigrate them. So they might not be suitable to compare to genetic instruction vaccines.
Yes.
But in general, when looking at an estimate of effect, it doesn't tend to vary. It doesn't jump around. It tends to sort of move down the same trajectory, but with the confidence intervals getting narrower and narrower and narrower as more evidence comes in. That's generally what Cochrane reviews find.
Right. Could you go back to page 62 in your report?
Yes.
And vaccines procured against COVID-19. Sorry. I'll do that later. I think again this is somewhat repetitive of what you've already said and what we've looked at. There are a number of individual, I think they're called pivotal studies in relation to vaccines, and I think we can see those referred to at page 63. And my Lord, and for the benefit of others, the Folligatti report is paper number 4.
Yes.
And is at pages 27 to 34 of the bundle. Sadoff is paper number 17 and is at pages 917 to 930 of the bundle. Pollack is number 13 and is at pages 864 to 876. Baden is number 2 and is at pages 5 to 18. And I'll also give the reference to Ramasamy, which was a follow-up report on the AstraZeneca vaccine, which is number 15, and that's at pages 887 to 901. Now, again, it may be useful, Doctor, without actually going through the what you actually say in your text, to go to page 64 and your comment, because you do make a comment on the AstraZeneca study.
Yes.
And perhaps you would just read that.
This is a comment on, it's really on Folagati, the pivotal study, and my comment is strength of the AstraZeneca study, Folagati, are that it is a randomized controlled trial, appears not to be sponsored by industry. It seems to be an academic study emerging from Oxford University, and limitations include, one, the relatively small number of participants, which is 1,077 in total, but 543 in the vaccine arm. Two, the use of a different vaccine as a control rather than saline, and that would tend to sort of result in a unrealistically favourable assessment of the study vaccine's tolerability, true tolerability. And three, the short period of follow-up, which was 28 days or 4 weeks, and four, the lack of a study flowchart in the published report, even though this is mandatory nowadays when you report an RCT.
Yes. And I think that's a reference to a document we looked at yesterday, Ultimate.
That makes it very difficult to understand what they were doing.
The Janssen vaccine, which you refer to at 4.1.2, I think probably, again, with respect, we can ignore, because I think, as you've already indicated, it is not a vaccine that was made available in the UK or in Scotland.
No, that's right. Yeah.
One goes on, if I may, then to the Moderna vaccine at 4.1.3, and again we can read what is said there. The pivotal study was the Baden paper, which I've given reference to. I think we can see there were 30,000 plus participants, and you make a comment on that at the top of page 66. And again, if you'd read that, please.
Yes. So strengths of the Moderna study are that it's a randomized controlled trial, so that's the gold standard of evidence, and it uses a true placebo. The placebo was saline. Yep. And then the trial incorporates a nice study flowchart, so it's very easy to see what was done. And limitations include, one, it's an industry-sponsored study. It's sponsored by Janssen, which is a Dutch company. So inevitably, with industry studies, there will probably be some reporting bias. And two, there are differing follow-up periods for different participant groups, and that's confusing. It's confusing to me anyway.
I think you said that it was sponsored by Janssen. I think this is the Moderna.
I'm sorry. Sponsored by Moderna. Beg your pardon. Yeah, Moderna, which is an American company.
Yes.
Yeah, big. Janssen was the Dutch company. Moderna is an American company, which got a lot of, as we were saying yesterday, got a lot of money from the U.S. federal government for this development of this vaccine.
Yes. You then go on to 4.1.4 to look at the Pfizer vaccine. Pivotal study is the POLAC study, which I'm given reference to.
Yes.
There's a follow-up study to that, which is Thomas, which I'll give the reference to. It's paper number 19, and at pages 937 to 949.
Yes.
Could you just again go to the comment that you make in relation to the Pfizer vaccine?
Yes, so the strengths of the Pfizer study are that it is a randomized controlled trial. It uses a true placebo, which is described as saline, which is good. It incorporates a study flowchart, nice study flowchart on the fourth page of the study, page 867.
So that makes it Altman compliant, if I can put it that way.
It makes it Altman compliant, yeah, of course. And you can see exactly what they're doing. But interestingly, in the next study, it's pretty much exactly the same flowchart, which wasn't what I would have expected. But there we are. And limitations include, one, it's an industry-sponsored study, sponsored by Pfizer, a very wealthy company that invented Viagra, and that's why they're so wealthy. And that's why they were able to fund this study entirely without outside interference. Hence, its reporting is liable to commercial bias. And a second, short period of follow-up for the majority of participants. Oh, Shall I kind of want further comment?
Yes, you make a further comment.
So further comment. And in September 2021, there was a follow-up study by Thomas, and this was meant to sort of carry the story forward, because all of these, as far as we can tell, all of these 4 products were given authority to supply, approval to supply. It was not the same as licensing in the UK, on the basis that the participants would be studied up for 2 years. So they're meant to be 2-year studies, but what happened was that the study participants started to drop out in massive numbers.
Yes.
So what I put here, there were multiple dropouts from the original pivotal Pfizer study, so the study in effect had shrunk in size, and the follow-up study found that vaccine efficacy declined at an average of 6% every 2 months, which hadn't been anticipated in the original study. And the lack of transparency in the data presented by Pfizer in this follow-up study was strongly criticised in an online editorial in the British Medical Journal, which I cite as...
Yes, you've given us that reference, and again, from my Lord and those following, that's document number 3, at pages 19 to 21
yes.
of the bundle. And perhaps just to understand what the criticism was, can you just tell us what Mr. Doshi was saying?
I'll refer to his papers.
Yes,
Quite hard to follow some of his arguments, but he seemed to be making a number of, I thought, rather valid points, which is why I included them, my lord, in the study. So, yeah.
Yes, I think it's at
Yes.
pages
So-
19 to 21.
Yes. So what he seems to be commenting on, my lord, is a preprint of Thomas 2021, when we would have expected the study flow diagram to continue for another 6 months, but in fact his study flow diagram is the same as the previous one, which is a bit odd. And so he's really, what he's saying is that really all it's doing is, all the preprint is doing, as Kodesh Doshi, is measuring, again, telling us what vaccine efficacy was at 2 months. Well, there purports to be a study taking the story forward because of the way they presented the data. It doesn't actually add any more information. And he says this, and this is Mr. Dr. Doshi saying waning immunity is a big problem with influenza vaccines. If vaccine efficacy wanes over time, the crucial question becomes, what level of effectiveness will the vaccine provide when a person is actually exposed to the virus? And he says, unlike COVID vaccines, influenza vaccine performance has always been judged over a full season, not for a couple of months. And Mr. Doshi talks about the Israeli experience of...
Yes, I was just going to draw your attention to that.
Right, yeah.
At midway down,
Yes.
page 19,
Yes.
just below halfway down 19,
Yes.
Dr. Doshi makes reference to the Israel experience, which I think we did touch on earlier this morning.
Yes, yes. And then Dr. Doshi says we have to take his word for it. For the FDA, the Food and Drug Administration, I believe he's based in the United States.
Right.
Dr. Doshi. He says they expect a vaccine, an approvable vaccine, to be have at least 50% efficacy. So he says here that the Israelis had found that the Pfizer vaccine efficacy had fallen to 39% when the new variant came along, the Delta variant, and so he considered this to be pretty poor performance. And then he says, well, okay, what's happened? We've now got this booster. He puts booster in inverted commas because I agree with him. I think the booster is a misnomer. It's actually an add-on to try and get the vaccine up into the stratosphere. The booster is what you use when you've already achieved immunity, just to keep the immunity going. And then he talks about US plans for all fully vaccinated adults to have a booster. And he says more about, he said waning efficacy has the potential line to be far more than a minor inconvenience. Vaccines, the bottom line is vaccines need to be effective, especially when new variants are circulating. It's unclear whether the two-dose series, yes, so it goes back to the two-dose series, the original primary course, which was presented as the solution to COVID-19, and he says, would this even meet the FDA's approval standard of 6 or 9 months for a vaccine? So what he's saying is, I think what he's saying is, in a way, we were sold a pup. In a way, we were sold a product that wouldn't have met the ordinary FDA regulations under normal circumstances.
So I think essentially what Dr. Doshi is doing is it's an online editorial, and like
yes,
many online editorials, the writer tends to like to pose questions without necessarily providing you with the answer.
Yeah, we looked yesterday at Fiona Godley's editorial after the swine flu vaccine. She was pretty angry as well, and he's obviously quite angry. So.
Yes. Okay. Can we go to 4.1.5 at page 67?
Yes.
Which is the COVID-19 vaccination timeline. Just on the question of timeline, I think you previously indicated that you'd had regard to the inquiry timeline. I think the timeline you've been given is what's called the SPICE timeline.
Yes, it is, yes.
Yes,
right.
and that's a timeline that was provided by the Scottish Parliament.
Right, oh, thank you, Mr. Gill. Yes.
So you begin at 4.1.5 by saying that on the 8th of December of 2020, the first vaccinations against COVID were given in Scotland to those who would be carrying out the subsequent population-wide vaccination programme.
Yes.
This included both medical and non-medical personnel. And then the milestone of care home residents and staff were vaccinated from the 14th of December 2020 onwards, and high-risk clinical groups were offered vaccinations in early 2021. And then you list the various milestones from then right through to to the end of 2021. And I think we can see it as at December 2021. You make reference to it being the 1-year anniversary of the first COVID vaccination in Scotland.
Yes.
Since then, 4.3 million first doses have been administered, 3.96 second doses, and 1.9 million boosters, and third doses have been administered from around 1,200 locations. So you then go on to make a comment, and I wonder if you'd just read that, please.
Yes. So, comment. The COVID-19 vaccination programme in Scotland continued throughout 2022 and is still in place in 2023. In autumn 2022, the MHRA approved bivalent vaccines from Moderna and Pfizer. So those are vaccines that are designed to provide protection against the original strain of the virus and also and the variant strain, one variant strain. And the vaccination milestones are summarised in Appendix 9 to my
I think
report.
it's actually Appendix 10, but
Oh, is it
it makes little difference. I think we can easily find it. Right. You then go on at 4.1.6 to refer to vaccine adverse events reported in the UK.
Yes.
I think we can probably work it out. But what do you regard, or what do you and other public health practitioners regard as a vaccine adverse result event? Rather?
Yes, there's a fine distinction between an adverse event and an adverse effect.
Yes.
An adverse effect is considered to be indisputably linked to the drug or vaccine being considered. An adverse event will be something that's reported, usually in the early days, but often and later on in the history of drug or vaccine. And adverse events is simply practitioners, healthcare practitioners, doctors or nurses, and nowadays members of the public can report any untoward physical or psychological or mental problem that they think is linked, they consider is linked to the prior taking of the drug or use of the vaccine.
And that's in part the yellow card referral.
It's done through the yellow card system, yeah. For doctors, there was always at the back of the British National Formulary a yellow card, which was pre-printed, and if a patient to whom you prescribed a drug, and it would usually be a kind of novel drug, had a funny reaction to it, and you thought, well, this is odd. I need to report that to the precursor of the MHRA. You would fill out the card and send it off. And there was always a lot of under-reporting, but responsible doctors would try and report adverse events, even though they may not even become aware of them. Some patients would die. You might give them a drug, they might die, and you might just never really link it to you having given them a particularly powerful drug. That's part of the difficulty of spontaneous reporting systems.
Can we go to the bottom of page 69 of your report and what is said at 4.1.6? And perhaps you would just read from the beginning of that. Some of it, I think, is material you've now already covered or alluded to, but perhaps you just read what you say.
So on the 1st of December onwards, on the 1st of December 2022, the UK Medicines and Healthcare Products Regulatory Agency, MHRA, published a summary of the spontaneously reported adverse events, known as yellow card reporting, that had been received by the agency between the 9th of December 2020 to the 23rd of November 2022. And the December 2022 MHRA publication, here this would look like, my lord. So it lists 2,362 yellow card reports with a fatal outcome. In other words, where the person had received a vaccine and they died, and somebody, maybe a doctor or a relative, reported it as linked to the vaccine. And of these, 1,044, or 47%, were in females, and 1,189, in other words, 53%, were in males. And of these reported fatalities, 809, with 34%, occurred in people who were aged less than 69 years, so relatively young people. And then during the 2-year period of assessment by the HMRA, vaccine-associated adverse events, other than fatal events, so non-fatal events, were reported as follows. With AstraZeneca COVID-19 vaccine, a huge number of reports, 246,866. With Moderna, there was fewer, 47,045, and with Pfizer, there was somewhere in between, 177,000 and 900. So it's a very large number of reports. What I couldn't get from the report was how many doses have been given, what's the proportion of the number of doses given, but just taken as ball numbers, very high numbers, and far more than you would expect to see with vaccines. So my comment here, a reported adverse event from a drug or vaccine, for example, sudden death, does not prove causality, although adverse events that are reported frequently and consistently often do point to a true causal association. The risk of vaccination needs to be weighed against the risks of severe COVID-19. Historically, the UK yellow card system for reporting adverse events has resulted in under rather than over-reporting. The MHRA's December 22 report on the potential harms of COVID-19 vaccines may therefore have underestimated the scale of the vaccine-associated harms rather than overestimating it. Shall I carry on?
No, just please carry on, yes.
So, leaving aside fatal events, analysis by the MHRA of 2 consecutive years, so they were looking at 2021 and 2022 up until November, and then they stopped analysing. It strongly suggests, I'd say, that COVID-19 vaccination may cause an increased risk of the following serious adverse events, and then I list.
You list them.
And these are ones that they themselves have highlighted as coming up a lot. And so anaphylaxis, that means immediate onset life-threatening allergic reaction. They reported they had received 990 reports, mostly with the AstraZeneca product. Bell's palsy, which is a unilateral facial nerve paralysis, so half of your face becomes paralysed. They seem to imply that they got a lot of reports of that, but the numbers weren't in the report. At least I couldn't find them, and they say that it's continuously reviewed. Right, that's what they say. Although at the end of the report they tell us they're stopping routine reviewing, which is a bit odd. Guillain-Barré syndrome, which is paralysis of the lower limbs. It's occasionally seen with other vaccines, but with these particular vaccines, it seems to have been seen quite often. Again, the actual numbers were not disclosed in this report, and at least I couldn't find them. Immune thrombocytopenia, that means, and that sounds pretty grave, because that means you haven't got very few platelets, so you're going to have severe problems with clotting. You won't be able to clot your blood if you cut yourself. And then major thromboembolic events, that means serious, very serious, life-threatening blood clots. And there were 486 reports to the MHRA of these, mostly with AstraZeneca, though again, we don't know what proportion of the vaccines administered were AstraZeneca, but I mean, assuming they were 1/3, they clearly have been strongly associated with AstraZeneca. Menstrual disorders, huge number of reports to MHRA, 51,000, and the MHRA says they were mostly transient, and we will continue to review this problem. Myocarditis, that's the inflammation of the heart muscle. Again, very large number of reports to MHRA, in my view, 1,241 in total, and 15 of these were reported as having a fatal outcome. And the MHRA comment is the reports are being monitored closely. Pericarditis, which is inflammation of the fibrous sac surrounding the heart. Again, a very large number of reports to MHRA, which were associated with the vaccine, at least in the people reporting them, 954 of these. And finally, transverse myelitis, which is rather rare, very, very rare inflammation of the spinal cord, going right across the spinal cord, would cause paralysis of the limbs, and 179 reports in total, again, most of these originating from vaccination with the AstraZeneca product. And the comment from MHRA was
perhaps can we just I'm sorry, I think you're going on to the comment on transverse myelitis.
Yes.
That the product information has been updated.
Yes, indeed, yeah.
Can we just stop there, Doctor? Because
yes.
We have to be mindful of the burden on the stenographers, and I think we've passed our normal time, so perhaps we can just stop there, and we'll return to finishing in a few minutes.
Very good. Thank you.
Thank you, my Lord. Dr Croft, just another few hours. Can we go to page 71 of your report, please?
71.
You've got a comment section. I think that's as far as we had got in your read-through. Would you read the comment section in its entirety, please?
Yes. Comment. See the scientific knowledge box on page 62 of this report, and that was summarising the key messages from Grant. Of COVID-19 vaccines states that it is unclear as to whether or not vaccination has made any difference to the numbers of deaths from COVID-19. And there's a quote from the Cochrane Review. Quote, there is insufficient evidence to determine whether there was a difference between the vaccine and placebo in terms of death, because the numbers of deaths were low in the trials. And the future updates of the review may resolve this important point. Minor adverse events, e.g. fever and headache, occur commonly with many of the currently available COVID-19 vaccines. For many of the currently available COVID-19 vaccines, serious adverse events, e.g. Cardiac and neurological events and sudden death, appear to be few based on the reported RCTs. However, this apparently low number may be due to, one, the very short follow-up period in many of the reported vaccine RCTs. Two, the fact that the candidate vaccine was not compared against a true placebo. Three, the number of participants in the reported RCTs was small. Four, the RCT participants were optimally healthy at time of vaccination or were otherwise unrepresentative of the majority of the UK population. Or five, a combination of any or all of the foregoing. In early 2023, MRHA announced that it would no longer be issuing special publications on the spontaneously reported adverse events associated with COVID-19 vaccines, although they do say that, this is the last of its kind, they do say that they will report on the autumn booster for 2023, and the reasons for this announcement are unclear. And around the same time, for reasons that are also unclear, the December 22 report, that's a 2-year report, this one was removed from the agency's website. At least I couldn't find it when I tried to find it on there. But by good fortune, I downloaded it, I think, around about Christmas when it came out, so I had a copy.
Finally, in relation to this, can we go to the MHRA document, please? This is a summary of yellow card reporting published on the 1st of December 2022, as you've just said. Can we go to page 819 within the second bundle of documents, please? Now 819 shows us the cover sheet, coronavirus vaccine summary of yellow card reporting, published 1st December, and the data included data from the 9th of December 2020 to the 23rd of November 2022.
Yes.
And we go to paragraph, page 819 within that document. And I think we can see there, this is the summary section. And reading the first 4 paragraphs, I think, is perhaps of particular interest, and I'll just read those to you. Over the first 27 months of the pandemic, over 178,397 people across the UK have died within 28 days of a positive test for coronavirus. Vaccination is the single most effective way to reduce deaths and severe illness from COVID-19. A national immunisation campaign has been underway since early December 2020. Now again, as a public health consultant and epidemiologist, is that a general statement with which you would agree?
Thank you, Mr. Spear. If I could refer you back to Altman, Doug Altman, and his statement. So that is quite a powerful statement, and Doug Altman says, that's in the bundle of documents, my lord, only randomized trials allow valid inferences of cause and effect. And so therefore, I would expect that statement there, vaccination is the single most effective way to reduce deaths and severe illness, to be supported by the evidence from randomized controlled trials. But that isn't what randomized controlled trials show at the moment.
Yes.
It may do at some point in the future. But
they may do it at some stage in the future.
Yes, they may do.
Yes. Right. And then the document goes on, 3 COVID-19 vaccines, the Pfizer-BioNTech, the AstraZeneca and the Moderna were used in the primary and booster vaccination campaigns up to the end of August 2022.
Yes.
All have been authorised for supply by the MHRA,
Yes.
following a thorough review of safety, quality, efficacy, information from clinical trials.
Yes.
In clinical trials, these vaccines showed very high levels of protection against symptomatic infections with COVID-19. Data are available on the impact of the vaccination campaign in reducing infections, illness and mortality in the UK. And then it goes on, the MHRA confirmed on 9th September 2021 that the COVID vaccines made by Pfizer and AstraZeneca can be used as safe and effective booster doses. Following a review of the data from the COVID-19 vaccine, for the COVID-19 vaccine, Moderna vaccine, the MHRA and Commission on Human Medicine experts also concluded that this vaccine can be used as a safe and effective booster dose. All vaccines and medicines have some side effects. These side effects need to be continuously balanced against the expected benefits in preventing illness.
Yes. Yes.
I think if one turns over the page to 820, there's separate comments on each of the vaccines, the Pfizer-BioNTech, and AstraZeneca, Moderna. And then towards the bottom of that page, one can see penultimate paragraph. The MHRA continually monitors safety during widespread use of a vaccine. We have in force a proactive strategy to do this. We also work closely with our public health partners in reviewing the effectiveness and impact of vaccines to ensure the vaccines continue to outweigh any possible side effects.
I'd like to know who these public health partners are. It's not really explained, but it's interesting.
To a certain extent, you take that on trust.
We have to take that on trust, yes, because the MHRA isn't really resourced to conduct epidemiological analysis of the reports coming to it. Not really. They count the reports. They're not like NICE, National Institute of Clinical Excellence, who do. They can assess the benefits and harms of new drugs. So the MHRA isn't really like that. They would depend on other people to do that for them.
If one goes to page 821, in the first full paragraph, I think we can see that as at the data date, 23rd November 2022, 177,965 yellow cards have been reported for them. The Pfizer 246,866 have been reported for AstraZeneca and 47,045 for Moderna. And if one then goes to the bottom of that page, 3 paragraphs from the bottom, for all COVID vaccines, the overwhelming majority of reports relate to injection site reactions, sore arm, for example, and generalized symptoms such as flu-like illness, headache, chills, fatigue, nausea, fever, dizziness, weakness, aching muscles, and rapid heartbeat. Generally, these happen shortly after the vaccination and are not associated with more serious or lasting illness. And again, to the bottom of that page, the last sentence, overall, our advice remains that the benefits of the vaccines outweigh the risks of the majority, in the majority of people. Further comments on use in specific populations and details of the specific safety topics can be found within section titled Analysis of Data. And then we have a conclusion section there, and again we have a very generalized statement, which is vaccines are the best way to protect people from COVID-19 and have already saved tens of thousands of lives. Everyone should continue to get their vaccination when invited to do so, unless specifically advised otherwise. As with all vaccines, the safety of COVID vaccines is being continuously monitored. The benefits of the vaccines in preventing COVID-19 and serious complications associated with COVID-19 far outweigh any currently known side effects in the majority of patients. And then there's further, there's a reference to further information. So again, just ask you on the first part of that concluding section, is that something with which in general terms you agree?
Well, no, because again, the first part, it may be correct, but it's not demonstrated by the Altman rule, which is that only randomized trials allow valid inferences of cause and effect, and the randomized trials don't show that the vaccines have that effect in saving lives, preventing deaths.
Would it be right in saying, Doctor, that it doesn't satisfy your test and standard, but it might satisfy others?
Well, I consider it is my personal test. It's the professional test that all epidemiologists would use before making those kind of categorical statements.
But other epidemiologists might have a more liberal approach, if I can put it that way, to adherence to the Altman rules. So you might find others who disagree with you.
Yes. I'll just say again what the Cochrane Review says, and that's there is insufficient evidence to determine whether there was a difference between the vaccine and placebo in terms of death. That has to be a valid inference of cause and effect.
I think we do have some data at pages 825 and 826. Perhaps we could just look at that. And Table 1 discloses those who have received a first dose of a vaccine for COVID-19 up until 11 September 2022, and for Scotland the figure is 4.5 million. Second dose is 1.3 million. No, it's not. It's 4.285 million. And those who've received a third or booster, again, is 3.5 million. I think these are figures you've given already.
Yes.
In the terms of your report.
And yes, just to clarify what I've just said, my lord. So it's correct that deaths started to decline, if you like, as the pandemic progressed. But there may be other reasons for that, including what we talked about earlier, which was the better treatment protocols that weren't contributing to the patient's morbidity. That's just the obvious reason. So to say, well, the deaths were declining at the same time as the vaccines were being given to people is not scientifically sound, in my professional opinion.
Could I just, in conclusion, ask you to look at page 855 within that document?
Yes.
And I think these are tables 11 and 12, which show, first of all, the number of UK reports with a fatal outcome received for COVID-19 vaccines by a patient up to and including 23rd of November 2022. And so for all vaccines, the total is 2,362.
Yes.
But again, causality is not being established
Of
there.
course, yeah, and indeed, and the true number may be higher. It's likely to be higher based on historical underreporting, or it may be lower because there may have been overreporting. But it's what has been reported. That's the data as we know it.
I mean, it is possible there's just simply a coincidence.
Yes.
Between particularly an elderly person who has been vaccinated and subsequent death.
Potentially, although if you see very many of the very, very large numbers are in the middle-aged and young groups there, which wouldn't tend to give that kind of pattern of reporting.
I see. And I think also in table 12, you have that stratified into male and female.
Yeah, there doesn't seem to be much of a difference between male and females. Actually, rather slightly more males, actually. 53% of males, 47% of females. So there is a difference there,
yes. And I think we can inform ourselves on that if we look at the accompanying text at 854.
Yes.
And if one goes to the penultimate paragraph, you see a report with a fatal outcome on a yellow card scheme does not necessarily mean that it was caused by the vaccine, only that the reporter has a suspicion that it may have been. Underlying or previously undiagnosed illness unrelated to vaccination can also be factors in such reports.
Yes, indeed.
The relative number and nature of the UK reports with a fatal outcome are subject to many factors that influence ADR reporting. They should therefore not be used to directly compare the safety of the different vaccines.
Yes, I'd agree with the last sentence.
Yes. And could we just go finally to the conclusions on page 858. These are essentially the same conclusions that we've seen in the summary, and again draw your attention again to the what is said at the penultimate paragraph. The benefits of the vaccines in preventing COVID and serious complications associated with COVID far outweigh any currently known side effects. As with all vaccines and medicines, the safety of COVID vaccines is continuously monitored, and benefits and possible risks remain under review. And again, I understand the clarification that you've made in relation to that, a statement of that generality.
Mm-hmm.
And I presume you would make it again in relation to this.
Yes.
Right. Doctor, you'll be pleased to know we're nearly there.
Thank you.
Can we go to section 5 of your report, please? This is at page 73 and following. And this is a summary, what do we know now? So do I take it really here, you are giving from your perspective
Yes.
of a consultant public health physician and as an epidemiologist in particular, what is your professional and formed opinion?
Indeed, yes.
And these statements are statements which, in your view, are borne out by the material that you have considered
Yes.
and looked at.
Yes, Mr. Kennedy.
So on that basis, Doctor, would you just read through that section, please?
So summary, what do we know now? The COVID-19 pandemic of 2023, caused by a novel coronavirus, was a national emergency which threatened the lives of certain groups in society, the very old and those who are very sick, but especially the very old. Other groups, children, by which I really mean healthy children and healthy young adults, were not ever at risk of severe disease. By early 2023, the pandemic had abated, but there were reports of many people with long COVID and of other people with long-term cardiovascular sequelae of COVID-19 infection. So some bullet points about physical measures against COVID-19. These, I hope, all arise organically from what has been said earlier in the report. So first bullet point, from March 2020 onwards, and in common with many other governments, the Scottish Government recommended or mandated a range of physical measures intended to limit the spread of SARS-CoV-2, the novel coronavirus which was the cause of COVID-19. Physical measures recommended or mandated by the Scottish Government range from simple public health practices, the encouragement of frequent hand washing, cleaning of environmental surfaces, the use of PPE in hospitals and care homes, to coercive and or intrusive measures such as face mask mandates outside of healthcare settings, lockdowns, and there's a definition for that, enforced social distancing, and test, trace and isolate measures. Next bullet point, in 2020 there was scientific evidence to support the use of some of the physical measures, e.g. frequent hand washing and the use of PPE in hospital settings that were adopted against COVID-19. For other measures, for example, face mask mandates outside of healthcare settings, lockdowns, social distancing, test, trace and isolate measures, there was either insufficient evidence in 2020 to support their use, or alternatively no evidence. And the evidence base hasn't changed materially in the intervening 3 years, even though there have been 2 additional reports about face masks. It has been argued, final bullet point, that the restrictive measures introduced during the COVID-19 pandemic resulted in individual, societal and economic harm that was avoidable and that should not have occurred. And in fact, that's now one of the textbook standard points that seems to be indisputable. So vaccines against COVID-19. We have 8 bullet points. Firstly, vaccines against COVID-19 became available to the UK general public in January 2020. Initially, only the high-risk groups, the very old and the very sick, also healthcare workers, were targeted. Second bullet point, all the COVID-19 vaccines procured by the UK government during 2020 and 21 were nucleic acid vaccines using novel gene technology. But more recently, they had procured a couple of conventional vaccines. Thirdly, as additional vaccine supplies became available, vaccination was extended to young, middle-aged and elderly adults and to children.
Can I just stop you, Doctor? There is one small typographical error that it may be seen as being significant. In the first bullet point, I think the date should be January 2021.
Yes, thank you. Thank you, Mr. Gill. Yeah, thank you so much. So fourth bullet point, vaccination against COVID-19 became a prerequisite of travel to many countries, and some UK employers made it obligatory for their workforce. Fifth bullet point, it remains unclear as to whether or not COVID-19 vaccination has resulted in fewer deaths from COVID-19. COVID-19 vaccines have been shown in randomized control trials to be effective or probably effective in reducing the number of people acquiring COVID-19 or severe COVID-19. However, vaccine-induced protection against COVID-19 is short-lived, so there's waning immunity, which not mentioned at all in the MHRA report, I should add. Last point, because of the antigenic variability of all coronaviruses, this concept of them being a moving target, including SARS-CoV-2, it was foreseeable that the COVID-19 vaccines would only provide short-term protection against COVID-19, as is the case also with current vaccines against seasonal influenza. And finally, because the novel gene technology vaccines procured by the UK government have been tested on relatively small study populations, and had been assessed for safety over short follow-up periods only, rare and sometimes serious adverse effects, including reported fatal events, emerged once the vaccines had been used on a mass scale in the UK and in other countries.
Doctor, there's one point in your summary that I would like to touch on with you, and that goes back to the first page. It's the first section at page 73,
Yes.
and it's the second paragraph, a short paragraph.
Yes.
Other groups, children, healthy young adults, were not ever at risk of severe disease. Now,
Yes.
I think I understand
Yes. Yes.
the context in which you're saying that.
Yes.
But I think you're saying that in the
And a
context
population.
of a public health practitioner
Yes,
looking at large,
Yes.
and of course we know,
Yes.
and we will hear, and we know of instances where children and healthy young adults were at risk of severe disease.
Right. Yes, of course. Yeah.
Yes. Doctor, you'll be pleased to know that is all I have to ask you. No matter if His Lordship wishes any clarification, but at the moment, thank you very much for the report that you've provided and the work that you've done. And on behalf of the inquiry, I thank you.
Thank you, Sir.
I'm happy to say I've got nothing I wish to ask you. Thank you very much. I simply repeat what Mr. Gill has said.
Yes.
This is, of course, simply the first stage in the presentation of scientific evidence. There will be a considerable volume. At the moment, we can't be sure exactly how much. Further evidence of science or epidemiology in relation to COVID-19. And what we've heard today will no doubt figure in the evidence we hear in the future, because, of course, all subsequent experts who give evidence in whatever capacity will have the opportunity to see what you've written. But in the meantime, thank you very much indeed. I'm very grateful. And so far as the audience is concerned, my thanks to you for attending for 2 long days. I'm very grateful. And as I suppose they say in show business, I look forward to seeing you on the 28th, is it, of August at Murrayfield. Thank you all. Right.